um, really revolving around a lot of things going on in society, as we all know. And I thought this was a town hall time period, but I thought it would be a good opportunity to hear updates about what Mount Sinai, the School of Medicine, and the health system are doing to address racism, and asked Gary Butts to do a brief introduction. And then afterwards, uh, our own Cardi Smith will talk about some of her own research in implicit bias in healthcare. So, and we'll hopefully have some time for questions and discussion during this special lecture. So, Gary, are you available? Oh, there you are. Hi, Gary. Gary, just for people who don't know, let me just go ahead and give his titles. He's the Dean for Diversity Programs, Policy and Community Affairs, the Chief Diversity and Inclusion Officer for both the School of Medicine and the Mount Sinai Health System. So welcome, Gary. Dr. Butts, thank you.
Thank you, and thanks for the invitation. I will do my best to be very brief, but as you can imagine, this is stuff that requires conversation. And also for any of you who know me, and I see many familiar names in your department on the screen, these are issues for which I've been passionate about and privileged to lead for a number of, actually now decades now, for the school and more recently for the system. And so so let me begin. Thank you for your interest in this work. This is, timely. We have, for the past couple of weeks, not been immune to so much of what's going on across the nation and throughout our city that reminds us of the disproportionate burden of disease, illness. If it's not COVID, it's something else. This is not new. And then, particularly on communities of color, Black communities especially, and the focus on highlighting the violence, particularly for Black communities and others, has raised our attention. And so that we, about a week and a half, almost 2 weeks ago now, were part of a solidarity movement and bringing Mount Sinai employees together in a way to share the pain and suffering that was pretty deep and very moving. And if any of you haven't seen the video collage, please look at it. It's very moving. And so it demonstrates pain, suffering, but how we are coming together to embrace ourselves to move forward, and the promise. And so as a product of that, and of course there are lots of ongoing activities, a decision was made that we come together and figure out ways to understand where we are and what else needs to be done so that we begin to uncover some of the deep underpinnings that are getting in the way for us in making a great institution even better. And that is addressing one of the strong underpinnings to inequity and injustice, and that is racism. And uncomfortable as it is to talk about race, it's even more uncomfortable to talk about racism. But the frank reality is that unless we can do that, we cannot move forward. We cannot take advantage of the opportunity now, the momentum, and harness the energy to be that much more focused, deliberate, and addressing this deeply rooted ill. And so what the dean agreed to do was charge me with developing a task force, bringing the task force together. Eventually it was clear that this needed to be bigger than the school, and so this is now a system effort where that task force would help to lay out a roadmap that would help us to address short-term and a-moment issues. So there are some things that we have to figure out how to do better or address better now, and then over time, because clearly to get at, uncover adequately and develop interventions to address racism will take some time, some discomfort and some time. racism didn't come to be overnight. This is hundreds of years in the making, certainly in the United States. And we're not going to fix it, and we're not certainly not going to address it adequately overnight. So that's where we are. It is clear that we can do a better job in many ways as a start. And one is to listen deeply and more broadly across our institution. There's some folk who've been simply invisible and voiceless, and they need to be heard. Because in order for us to really appreciate impact that we've gotten anywhere, success needs to be clearly definable to those people just like to us. So we will learn with each other, through each other, and that will be very powerful. This, I think, allowing Cardi to do this presentation today is a great example of that. But then it's the dialogue around that I think helps us to be even stronger. We need to lead with accountability. I'm holding myself accountability, Dennis, Johnny, and Ken Davis holding themselves, and everybody on that task force. And guess what? You all too, because this is about all of us, not about Gary Butts or our diversity work alone. We clearly will build on what's going on now, including in your department. Connect the dots, that's the smart thing we do. But we all have to be activated, every one of us, in order to get this right, understand it and get it right. And so that's where we are. This will be a heavy lift, but clearly doable if we all play some role, have a hand in it. And so that when we look back in years from now, we can know that we really have leveraged this moment. And the default isn't where we are today, but it's much further along this trajectory. So that's where we are. And hopefully that wasn't much more than about 5 minutes. I look forward to working closely with all of you. Feel free to send me a note at any point. It's not clear what it will look like to connect all of the departments and institutes. We will do our best. A task force that was aimed to be 12 to 15 couldn't stop there. So it's already 35, 40 people. Just imagine trying to manage that. But I'm up for it. We all are just ready to dig in and do the absolute best we can with this opportunity. So let me stop there. I don't know if there's a chance for a question or two. If not, that's okay. I will make myself available along the way.
Thank you, Gary. That's really helpful. I don't know if there is anyone with a question. Please signal yourself. But if there is, I think we have time for a question. But I wanted to ask, I think people want to be able to help and, contribute and think about ways to participate. And I think maybe that we'll be hearing from the task force over time. So I think I heard you say that you're open to getting these comments directly to you as the chair of the task force. And, because I think that's what people struggle with. What can people do to help this mission at Mount Sinai in particular? I mean, they have other ways of doing it in their personal lives. And so I assume that you'll be as leader of the task force helping to get that word out about what people can do.
Absolutely. My only other question to that, my answer to that is we, again, building on our existing platforms of activity, which are broad, by the way, through our Office for Diversity and Inclusion, and in the school, the Center for Multicultural Community Affairs. Friday, tomorrow, what is today? Tomorrow, Friday is Juneteenth. And so that is for those of you who haven't checked that or seen the article in the Times over the weekend, that is the official date for when 155 years ago, slavery ended in the United States officially. And interesting, it took 2 years for folk way out of Galveston, Texas to realize that, right, that slaves were free. And so that's a point of celebration. This year will be particularly important for reflection. The governor has made an executive order that it will be a holiday even this year for state employees, and over time it will be a state holiday for all. And Mount Sinai will be participating in that. And the note that went out broadcast yesterday, there may even be a link, but certainly if you go to our Office of Diversity and Inclusion site, we have a news site for solidarity that is loaded with information, and also an area where you can plug in questions or how you might want to be involved in all of our work, which is huge.
Great.
So that I just leave it with that, and certainly I'm open to like all of you. I get hundreds of emails a day. 1 or 2 more won't make the difference, and I do my best to be responsive. So
thank you.
Yeah, and thank you. Well, it was good to see you. I don't get to see you as
I know.
but I know you're still here, still hard at work.
Thank you. Thank you very much, Gary.
Thank you.
Okay, I think Ramon, did you want to say a few words?
Yeah, well, first of all, yeah, Ramon here, Ramon Parsons. Gary, thank you so much for those that perspective and insight and your initiative. A couple of comments. One is, this is not going to be the only time we focus on this issue for the Tisch Cancer Institute. This is just the first one. It was, we wanted to get something started immediately, and we thought Cardi would be a great presenter to discuss this topic. In terms of going forward, we also want to work on what are we doing to address the issue of racism and cancer in terms of different scientific forums that would be more outreaching and more communicative with the community and our constituencies. So we have plans for that I'll be reaching out to you about in the future. We're in the planning stages of something with that. And then finally, I think it's sort of all of us need to figure out ways to lobby for funding to be committed to this issue by the federal government. As you know, there's nothing better than a grant to get something to happen. And I think there's really been a dearth of federal funding on this issue. And I think, I have to be lobbying, and all of us need to lobby for this so we can have more substantive and long-term efforts in this area that just don't go away. And anyway, again, Gary, thank you so much for attending. And we will, again, and also any formal ties the TCI can have with your initiative, we can discuss offline with William and come up with a plan that is most beneficial and most efficient.
Thank you so much. And my only response to you, and Ramon, thank you for all of what you've done already and your team. It's been a great partnership. I think if everybody asks the question, if I were to have an equity lens on for this work that I'm doing or beginning to do or considering, what would, right? Just begin to ask those questions. Who's not here, and what would this intervention or this research project do to address who's not here? I think that begins to open up an additional series of questions. What's the relevancy for folk who aren't here? What's the and so you do that certainly with the grant if indeed it's specific to disparities, gender, race, ethnicity, and so on. But that's a lens that I think we need to have on more regularly for just about everything we do, everything we think about, including advocacy. So thank you for that.
Thank you, Gary and Ramon. And I'll go ahead and introduce our speaker for today, Cardi Smith. I don't think Cardi needs an introduction to this audience. She's an associate professor. Some of you may not know that she's double boarded in geriatrics and palliative care, as well as hematology oncology. She was recently named within the past year as the director of cancer quality for cancer services, and has been, as everyone knows, a leader during the COVID crisis, and has done a lot for our cancer patients. And this is her own research area, and again, I think this is the perfect time for us to hear about some of Dr. Smith's research. Cardi?
Great, thank you so much. I'm assuming you can see my slides.
Yes.
Okay, great. So I today will talk about some of the racial and ethnic disparities and bias that exists, of course, focusing on oncology and palliative care, since that's what I do, and then talk about some things that we know that are actually helping us move towards improving that. And so I feel I would be remiss if I didn't include this quote from Dr. Martin Luther King Jr. "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And so normally when we're live, I do this a little differently. So you'll have to give me a little leeway since we are in the virtual environment. I'm gonna ask you a series of questions, 12 questions, it's not a lot. And for each question, I want you that you respond with a yes. I want you to give yourself a point. So you get a point for each yes. And then I'm gonna ask you at the end of this in the chat box, just to write down what your number is. And I want you, as you think about these questions and you see the numbers that are coming in from other people, think about what that means for you in terms of where you are, not just in the world, but in the role that you play here within our system, and then also the role that you play when we take care of patients. So remember, you get a point for yes. If you are considered a person of color, yes. Do you have a visible or hidden physical disability or impairment? Are you an immigrant to this country? Is your native language something other than English? Do you feel that you cannot show affection for your romantic partner in public without fear of ridicule or violence? If you or a member of your family have ever been incarcerated or been in the juvenile justice system? If your parents or guardians did not attend college? If your family did not automatically expect you to attend college? Did your parents work night and weekends to support your family? Did you never attend private school or summer camp? Were you raised in a single parent household? Did you never have a maid, gardener, or cleaning service? Those are the questions. And now put your number in chat. I will tell you all, I'll start. That's my number. So as you look and you see all of these numbers scroll through, you see how different we all are, and yet we're all here. We all made it to the same place, but our paths and our ability to get here were very different. And the same is true for many of our patients. So I'm going to start off with just sharing my own story and how I got into this diversity work. So this is me on my wedding day in 2005. This is a much younger, pre-baby, pre-COVID eyebrow version of myself. And the man in the picture with me is my father. In fact, people say I look like him. I was named after him, so his name was Cardinal. That's how I got my name. And what he didn't tell me is that he was having rectal bleeding and had been having rectal bleeding for months. And then we fast forward to a year later, September 2006, and this is a picture on the day my niece, his first grandchild, was born. Although this picture is a little fuzzy, you know, you can see he looks older. He doesn't have that, you know, that as much of that pouch anymore, a little bit of gray hair. And that's because in April of that year, he had been diagnosed with stage 4 rectal cancer. And, you know, he didn't go get a colonoscopy when he was, I should say he was 52 when he was diagnosed. He didn't get a colonoscopy at 50 for many of the reasons we hear in the literature. Minority men tend not to do that. And then in 2007, so a year later, that's my niece on his lap. She was 11 months at the time. He died. We had many challenges during his illness, particularly around opioids. You know, he had significant pain. He had liver mets and had an enlarged liver that caused him lots of pain. He lived in Brooklyn, and yet it was a struggle to get his opioids from the pharmacy. The pharmacy often accused him of drug seeking if he came in a day earlier to do the refill because it was just easier for his schedule. They called his physicians to ensure that in fact he was getting the right prescription. I was actually a fellow at the time, and I ended up just filling his scripts here in Manhattan by the hospital because it was much easier. And then I would end up going into Brooklyn to give them to him. And so, you know, I was in the healthcare system, and if we had so many challenges accessing the healthcare system with serious illness, it really made me think, what do other people who perhaps don't have that same level of resources that I do to engage? And so that's how I got into this work. And so a healthcare disparity is really defined as a population is significant in disparity in the overall rate of either the disease incidence, prevalence, morbidity, and mortality when compared to the majority. And when we talk about when we talk about health equity, it really is defined as the highest level of health for all people and addresses avoidable inequalities, historical and contemporary injustices to really eliminate disparities. And when we talk about equity, this really is what we're talking about. I think we hear a lot, well, everybody has the same, everybody can go to high school. Everybody's given the same thing. We're all in the same playing field. But in fact, that's really not true. Some of us show up to this baseball game being much taller and being able to see the game, and others need to have more help and more assistance to be able to get over that fence. And this is really what we're talking about in terms of equity. It's really providing those resources in the amount and in the way those populations who need it can get it. And this is important because when we look at the US Census data from 2010, and this is a census year, since this is 2020, we know when we look at those communities that are considered minority populations, we've seen an increase in the number. In fact, I should also add, it's projected by 2050, the current racial and ethnic minority populations are predicted to be the majority. And when we look at census data right here in New York City, so here, this is Central Park, and this is right here where Sinai is, you can still see New York City's pretty segregated. So in this map, the blue represents white populations, the green, black, red, Asian, and yellow or orange, Hispanic. And you can see that the color codes are pretty distinct. And that leads to other forms of disparities. When you look at life expectancy at birth in New York City, you can see that there's a significant difference if you just go 6 train stops on the subway. So that in East Harlem, we're talking about an average of 76 years, whereas on the Upper West Side, we're talking about 84 years. And so this is how our social determinants of health translate into disparities, and we'll talk a little bit about that. And I, of course, would be remiss if I didn't talk about the fact that socioeconomic status certainly plays a role. It is a factor. But even once you control for that, just simply being a person of color can impact the healthcare that you receive. And so I know there's actually like websites set up to talk about whether or not Jake could have gotten on that float with Rose, or Jack could have gotten on the float with Rose, and I think he could have fit. But regardless, there is a difference between, on the Titanic, there was a difference between survival, whether you were first class, second class, or third class, with those in third class having lower survival rates. And in fact, we fast forward to 2009. This was the famous miracle on the Hudson when the pilot, Captain Sully, was able to land the plane in the Hudson River. And I think this is a pretty iconic picture. And yet it still shows how disparate things are. So I had never really noticed this before. But if you look at this picture, you see the people in the front of the plane are sitting on the life raft, right? That's first class. But these poor people in coach, they're standing on the wings, getting wet, and they're cold. And so inequities abound even today, but thankfully they all survived. When we look at the number of Americans living under the poverty line, again, you can see that poverty really impacts racial and ethnic minorities. And so we can't forget about the way this plays a role. I'm going to walk you through a little bit of history of healthcare disparities in this country, and by no means is this comprehensive, but probably some of the biggest names or the biggest issues you've heard from. So this is the infamous Dr. Sims. He was a gynecologic surgeon, and he's most famous for performing procedures on Black women, on slaves. And he performed these procedures, gynecologic procedures and exams, without anesthesia. And he really mutilated these women. And one of the reasons he stated he didn't need to use anesthesia is because he said Blacks have a higher pain tolerance and a higher threshold than whites. We fast forward, we have Henrietta Lacks, and if you've not read this book, I highly suggest reading it, particularly for us, because I think it touches on lots of things that we deal with. But Henrietta Lacks was a young woman who unfortunately died at the age of 31 from cervical cancer. And in the process of being diagnosed with this disease, she had a biopsy, and her cells were immortal. So her cells continue to move on, and in fact, helped contribute to many of our current scientific advances, including the polio vaccine. And what's most fascinating, and there are many fascinating things about this, but as you read the book, what you hear is that even generations later, to this day, her family, who never were, they never received any money for these cells that have made lots of other people money, still suffer from all of these inequities that we hear about. Many of them didn't graduate from high school, let alone go on to college, and they suffer from diabetes and other health comorbidities. Despite the the role that she has played in modern medicine. And of course, the most infamous Tuskegee syphilis study or experiment. And this is a paper of how they advertised. So here you see this started in 1932, and researchers told men they were being treated for bad blood, which was a local term used to describe several ailments, including syphilis, anemia, and fatigue. And here you can see they published the study, the untreated syphilis in the male Negro. And the study was finally unearthed in 1972. So this study went on for 40 years, where approximately 400 Black men were given syphilis and were not treated for it. Despite the fact that in 1945, penicillin was accepted as treatment for syphilis. And the study ended in 72. In 74, there was a $10 million settlement that was reached. As part of that, the US government promised to give lifetime medical benefits and burial service to all living participants. That was subsequently expanded to their wives, widows, and offspring. And so the last study participant died in January of 2004, the last widow in January of 2009, and there are currently 11 offspring that are receiving medical and health benefits as a result for this study. And to walk you just very quickly through what the health timeline looks like to get a sense of why we're still so behind. The Tuskegee syphilis study became public in 72. And then it wasn't until 1985 that the Department of Health issued the Heckler Report, which was the first report that really said that there were inequities in healthcare and that Blacks and other minorities disproportionately experienced more deaths for certain diseases than whites. 1985, that's within my lifetime. Then in 93, the Health Revitalization Act established the Office of Minority Health Research, but the first major legislation focused on reduction in health wasn't until 2000, and then out of that came several reports, including what was formerly the Institute of Medicine report about unequal treatment. And then in 2010, as part of the Affordable Care Act, the National Institutes of Minority Health was formed. And that is particularly important because, as Ramon mentioned, in terms of getting grants and funding, this really was now an institute within NIH to focus on healthcare disparities. And so these are all of the publications that came from that work. And it's complicated, right? I think when we think about health disparities research, there really is no one magic bullet. There are all of these domains and levels of influence that impact how communities of color receive care. And when we talk about the social determinants of health, there are so many components that go into that we as physicians don't control all of it, right? Which is why it is important to partner with the community and other organizations to really impact the way minorities of color receive care. And probably what is our current most contemporary big issue here was COVID-19. So the way social determinants of health have an impact has been amplified by COVID-19. So this is data just released this week from the CDC and captures data from March 1st to June 6th, looking at the age-adjusted COVID-19 associated hospitalization rates by race and ethnicity. And despite the fact that Black Americans only represent 13% of the population and Hispanics 16%, you can see that they disproportionately represent the number of patients who both have been infected, hospitalized, and died. And so these numbers here are rates per 100,000 population. And focusing on New York City alone, the story is the same. I would say the thing about this is that for the CDC data, only about 35% of the data that's received has actual race and ethnicity data. And so, we're not really even collecting race and ethnicity data systematically across the country, which makes a lot of this really challenging. I know through work that Dr. Butts and the Office of Diversity and Inclusion have done, they've really ramped up efforts to be able to include this data for us and SOGI data as well. And so if you give me a moment, I want to just frame what I like to, helps me think about this. This is work of Dr. Jones. She calls this the cliff analogy. So you have these levels of health intervention and you have these people here. And this is a cliff. And so if there are a bunch of people at the edge of the cliff and one falls off and there's nothing down there in D here to catch them, in E, that's it, they're dead. You put an ambulance down there at the edge of the cliff, then they have now ability to access acute emergent healthcare services. But why should we let them get that far along, right? So we put these nets up, these safety nets. These may be community services, it may be urgent care centers. But the problem here is that nets have holes in them, and so not everyone can access them, and some fall through. All right, so let's put a fence up at the edge of the cliff. Let's prevent people from falling. So the fence are like primary care, for example. Well, even better yet, let's just move people back from the edge of the cliff, right? Let's help them in their communities, give them the resources that they need. But we know that we live in a three-dimensional world and that there are multiple different types of communities. And so here in B, you would see two communities that would be the same, but we know that's not the case. So in C, you see that this ambulance here in the front, has a flat tire. So what happens when these populations, they may have these resources that exist, but they're not working well for everyone. Then in D, you may have some communities that don't have the ambulance. You don't have that acute setting care. You have some populations in E that don't have the safety net or the ambulance. And then in F, they don't even have the fence. And then in G, they're much closer here to the edge of the cliff. So if I were to use COVID as an analogy for this, you can think about these people over here as, the majority of the 1%ers in New York City that all flew to Florida when COVID hit. And you think here about the essential workers, right? The communities of color who already are challenged in terms of having access to care, having access to preventive programs, and now they all have to go into work. And so you end up here with differences in quality, access, exposures, and opportunities. And this is what really helps us determine social determinants of health. And where we want to go at the bottom here is social determinants of equity, where we allow communities to be equal. And so for the sake of time, I'm not going to read this whole thing, but we'll just say that the North Carolina State Board of Health in 1913 published this poem, Fence or Ambulance, which I think is so timely. And they really talk here about recognizing that people need help, and they end it with better put a strong fence around the top of the cliff than an ambulance down in the valley. And they knew this over 100 years ago, and yet we're still struggling. Why is that? What factors contribute to why we're struggling? Well, this was published in 2016, and this study one looked at lay people. So they asked lay people in the community these questions. And then study two looked at first year, second year, and third year medical students, and then residents, and asked them the same questions about beliefs of Blacks versus whites. And to highlight some of them, one question, Black skin is thicker than whites. You can see the lay people, about 58% of them agreed with that. And then while variations exist in medical students and residents, there is still about a quarter of residents, people who are about to be physicians in practice, that believe this. Blacks age more slowly than whites. While selfishly, I wish that to be true, you can see that there is a difference here, but yet still prevalent among our health professional colleagues. And then finally, when you look at the composite of these 11 items, about 22% of all of the people in the lay community believe this, compared now to 7% of residents. So it exists. Here you have a cartoon with a husband reading the paper saying, whites get better health care, telling his wife, I finally understand why Michael Jackson bleached himself. Sorry, any Michael Jackson fans. It's hard to know how my humor lands when I can't really see all of you. So the disparities conceptual framework really looks at access, receipt, and quality. I'm going to give you an example in each one of these areas, focusing first on access and using pain as an example. So the New York Times 4 years ago, finding good pain treatment is hard. If you're not white, it's even harder. And we know that there are physician and system barriers to this. and patient barriers as well. We know that physicians underestimate pain. In this particular study, physicians underestimated pain in 33% of non-Blacks as compared to 47% of Blacks, and there are multiple Black patients, and there are multiple studies that report this. Similarly, work done here 20 years ago by Sean Morrison, who's the chair of geriatrics and palliative medicine, he looked at adequate stock of opioids in pharmacies in the Harlem communities and the Upper East Side, and looked at the adequacy based off of racial and ethnic composition of neighborhoods. And what he found was that those minority neighborhoods, Black, Hispanic, Asian communities, had less access to adequate opioids. Particularly now that we're in the opioid crisis, I would be interested in seeing what this looks like today. So people have been saying this a lot lately, the system isn't broken, it was built this way. And hopefully as we get through this talk, we can talk about ways to sort of rebuild our own system. So now we'll give an example about receipt, continuing to use pain as the example. This meta-analysis looking across 1989 to 2003 basically shows that Hispanics and Blacks get less opioids compared to whites, regardless of the setting. And sadly, this data also translates to the pediatric populations as well. So there's been studies looking at appendicitis in the ER for Black children, showing that they also get less adequate analgesia. Work that we've done here focusing on communication, and thank you to those of you who participated in this. You may remember we had a grant supported by PCORI to evaluate factors impacting oncologists' time spent during goals of care discussions with minority and non-minority patients. And so the larger study was conducted at 4 sites here, Kings County, Yale, and BI. And the intervention was a grand rounds where we talked about why communication was important, a 2-hour workshop, a role play with simulated patients to teach communication skills. And then we had 4 joint in-person coaching visits where we had our expert communication facilitators help out. We included patients who had advanced solid cancer with a prognosis of less than 2 years, were English speaking, and we set these visits up as first scan post-initiation of chemotherapy for advanced cancer. So at the time of this visit, the scan's either going to show progression or no progression, and then we recorded those visits. And so here's the breakdown of the patients that we enrolled. Ultimately, we were able to get 142 audio recordings. The vast majority of patients did not have progression of disease at the time of the recording. These are the characteristics of both the 22 physicians that participated and the 142 patients. This is just to show that we had, a very high rate of minority populations enrolled in this study. And here are our unadjusted outcomes. So overall, oncologists spent 5 minutes less with their minority patients compared to their non-minority patients in these visits sort of set up as having value conversations. This was continued to be significant for those visits that did not have progression. If someone had progression, there was no difference in the time spent. Importantly, we asked patients to rate the conversation to rate the quality of the conversation, and 70% of both minorities and non-minorities reported having high quality conversations with their physicians, and yet there was still a difference in time spent with minority populations, whether that goals of care conversation was rated as high or low quality. And when we adjust for patient insurance, education, income, progression status, and clustering within hospital, we still found that there was a 3-minute difference. So oncologists spent 3 minutes less with their minority patients compared to their non-minority patients. And the question is why? 3 minutes can be a long time. There are lots of things that can happen within those 3 minutes. I think there are a ton of variables. We currently are transcribing these conversations, and we're going to go through and do a qualitative review to get a sense of what's happening. Preliminarily, we have found that patients are talking less, minority patients are talking less during these visits, oncologists are asking less questions, and patients are similarly asking less questions. So this gets us into this issue of bias, and there was a recent study just this year published around bias in minority recruitment in cancer trials. We talk a lot that minority populations aren't enrolled in cancer trials in the numbers in which we would want them to be, and so this study really did interviews among cancer center leaders, PIs, clinicians, and research staff at 5 NCI centers, and they found 5 main themes. The first was that recruitment interactions with potential minority participants were perceived to be challenging. Potential minority participants were not perceived to be ideal study candidates. There was a combination of clinic-level barriers and negative perceptions of minority study participants that led to providers withholding clinical trial opportunities. And when clinical trial recruitment practices were tailored to minority patients, the addressing misconceptions to build trust was a common strategy. And then finally, some people just said race was irrelevant. They used that sort of colorblind method, which we know really doesn't work because a colorblind strategy essentially negatively affects communication, particularly in racially discordant interactions. And so now, if you will allow me, I'm gonna just stop sharing for a second. I'm gonna show you a video. And while you watch this video, I would like for you to tell me what you see and what you hear, and any things that this video clip may bring up for you. Can you see the video clip? Thumbs up? Okay, great.
Need some help here? 2 GSWs, hope you're in the mood.
What happened?
Drug deal went bad. Guy opened fire on Flyberg on 3rd.
Injuries? Yo, homies.
Single
This mother
GSW.
hurts.
To the left flank, vital, stable, good breath sounds, IV saline TKO.
Some guy shot me. Yeah, some guy.
It's always some guy.
All right, Doyle, get him into trauma 2. Malik,
17-year-old employee hit in the lower left chest.
check for weapons and needles.
Push it through and through to the right deltoid. BP's falling 90 over 55. Sinus tank at 120. 2 large bore IVs, a liter of saline in. O2 at 15 liters.
This one's more critical. Grab the portable from 2. H&H times across 4 units. Give me 2 units of O negative just in case. And a portable chest.
Can we give him something for pain?
Stand by with morphine. I guess you need to get hazard pay for slinging burgers these days.
Belly's tender. Set up a lavage.
Pulse ox is 92 on 15 liters. Hands up 1 gram.
You might have a peritoneal violation. Give him Suboxetine, same dose.
What do you got?
I got a cake for you to walk. Exam 2. I need a surgical consult on a lovely 50-ish crackhead sent over courtesy of the St. David's ER.
Oh, that sounds like a dump.
Yeah, well, you lost fair and square.
What about this guy?
But forget it, Carter. It's Gomer Tag and you're it.
I can't believe he shot me.
Where's Malik?
Calling radiology.
I was just standing there, man.
Be quiet and hold still so I can
You
use
okay alone?
Yeah. I didn't have a gun or any needles.
Gun? I don't want no gun.
Call me if you need me.
Can I help you?
Yeah, I'm looking for my brother. He's been shot.
Visitors can't go in during a trauma. Go to the desk and tell them you're here. Someone will come talk to you.
Kenny! Kenny, you all right? Chris, I got shot.
You have to wait outside.
It's my little brother.
Okay, but you still need to wait outside.
Look, the cops won't let me pass the tape. The medics won't let me in the ambulance. I'm staying right here. Got you, Kenny. I don't know. Give him something. They think I'm a gangbang. Oh!
I haven't finished assessing him. Please, wait outside.
Positive.
Page Benton.
Why y'all swarming around this boy? Huh? My brother's in there dying.
Nobody is dying anywhere. Please, family members need to wait outside.
Are you in charge?
Malay, could you,
You sending no sister over there to shoot me away? Get your ass in there. Fix him up now.
we treat the most critically injured patients first.
Kenny's been shot.
You are tying up the staff and delaying your brother's treatment. So why don't you wait outside?
We got work to do.
You think he's a gangster?
We treat everybody the same.
Same? Same for the white boy? One for the brother?
Dr. Green, I need you in here.
Lydia, come with me.
He braided down his BP, bottom out.
Do you have anything?
No.
All right, give me a 14 gauge.
Pulse ox is only 85.
Lungs sounded okay to me.
He's got tension pneumo.
Set up the floor seal. Sterile blood, 7.5.
Get that portable in here.
Neck veins are coming down.
What happened?
You've got to constantly reassess a penetrating trauma.
What's wrong with him?
BP's only 70 palp.
Doyle, I'm going to put in the chest tube, okay? You set me up with a 32 French.
I told that doctor my brother needed help.
Now, your brother be fine. What's his name?
Kenny. Kenny Law.
Southside basketball kid?
Yeah, man, you got to represent for him.
Yeah, he was all city point guard.
So lots to unpack there that we would normally do in a very different way.
Black man, you doctor?
Yeah. But you can feel free to type some of your thoughts about what you saw while I start sharing my screen again. I will tell you that, that to me was an example of bias. That, Dr. Green was, we treat everybody the same, but yet they assumed that the Black person with the bandana tied around his head was the gangbanger, and the white person was not. And the white person got pain meds, but the Black guy did not. And it wasn't until he heard that the Black guy was, this all-star basketball player that, all of a sudden his facial expressions and things changed. And so, yes, that there was profiling, there was stereotyping, and yet I would challenge and argue that these things do happen, and they may not happen in a way that our eyes are open to see them as egregiously, but they do happen. And so this brings us to this concept of bias. And this question that really is, how could well-meaning and highly educated health professionals working in their usual circumstances create a pattern of care that appears to be discriminatory? We're not bad people, but we are taught things as we grow up, things that we believe and tuck away into our unconscious. And then it comes out in moments of stress, in times when we're operating automatically. And so there's something called the implicit association test, which is by Harvard, and this is the website there if you choose to go take it. Essentially is the premise is that it says individuals will respond faster to concepts that are strongly associated compared to those that have weak associations. So if you match white with good and Black with bad pairings, then that means you have a preference towards whites, versus the other, which is if you match Black with good and white with bad. And when we look across lay communities, about 70% of all people have a preference towards white, whether that's slight, moderate, or strong. And the same is true for healthcare clinicians, so that there's about a 66% preference towards whites. So I can't leave this in a bad note. I think that there are things that we are doing to move towards health equity. And for us in particular, one of those things for our communities of color can be palliative care. Work that we did here several years ago, where we looked at patients who were admitted to the hospital with an advanced cancer. And we looked at those patients who received a palliative care consult. And so 72% were non-minorities, 28% were minorities considered Black or Hispanics here. And there were differences by cancer type and religious preference. But at baseline, the minority patients reported having higher symptoms as measured by the Condensed Memorial Symptom Assessment Scale. And they reported, less active engagement in their advanced care planning, which we see in the literature. However, after palliative care consultation, all of that then went away. And the populations were very similar, except for worry, and that minority patients were worried much less. I'm okay with that. And then here you can see that there are policy changes that may impact this. So this is the percentage of uninsured adults by race and ethnicity in the US between 2010 and 2018. What happened here to cause this decrease in the uninsured? Yeah, exactly. The ACA, the Affordable Care Act, or Obamacare, as it may be called. And here you can see, that for those states that expanded Medicaid, here light pink is 2013, dark pink is 2017. And for all expansion states, there was a decrease in the number of uninsured. The Hispanic population experienced the highest magnitude of a decrease. And this just represents people at the poverty level. And we know at the plenary presented at ASCO last year that in fact, those states that expanded Medicaid, those patients with cancer were able to access cancer services in a more timely manner compared to those states that did not expand Medicaid. So This is the infamous picture. Now that we know there's a problem, right? What are we going to do about it? Work that we're doing here, work that I'm doing with Nina Bakel, we've created a cancer disparities dashboard, really focusing on those cancers that hit us the most in our catchment area. And we want to be able to look at this data and see where we're seeing differences in terms of these particular outcomes that are listed here. So this is working with our cancer registry to create this dashboard. This is a high level overview of what it looks like when you first get there, but you can drill down by cancer type, by treatment received, by race and ethnicity. And I'm just going to highlight here breast cancer, stage 4 from this time period. We can look at hospice. This is specifically rates of hospice referral. And you can see that there is a difference. And so work that we want to do is really start looking concretely at these different cancer types and looking to find what differences exist. And want to partner with all of you through the DMTs as a mechanism to identify what you think is most important for the cancer types that you take care of. And so I have to leave you with some action items. The most important one is vote. November 6th happens to be my birthday. It is, I think this year election is November 7th or the 5th, I can't remember, but give me a really great birthday present this year, everyone, please. And not just vote for yourself, but sign up 5 others. My nephew is 18 and I got him to sign up 5 of his BFFs to vote. I want them to vote my way, but more important is that they just vote. Fill out the census. This is the census year. The census really impacts who represents us and how our communities receive services. Consider implicit bias training and anti-racism training. There's a lot of work that's been going on at this institution over the last several years to do this training, and I hope to be able to find an avenue to bring that to all of us. Screening for social determinants of health. I think this is something that our social work colleagues can do well, but I also think you have to talk about it. Some of the things that I do with my lung cancer team as we go through this, are there food insecurities? Are there transportation issues? Are there financial issues? What's impacting this patient's ability to get the care that we would want them to get? I think there has to be a concerted effort to diversify our oncology workforce. We are a preeminent training program, and there is no reason that we should not have higher levels of underrepresented minorities in medicine trainees who come through here. Only 5% of all Hem-Onc board certified physicians self-report as being Black or Hispanic. So that is a problem. I think being intentional in your patient encounters and thinking about, why am I not performing standard of care for this patient? Is there a reason, a clinical reason, or is there a bias that's pushing me towards this? I can share with you that in my clinical encounters with my team, whenever we choose to do something that's not standard of care, I ask them, why am I doing this? Push me to make me tell you why I'm doing this, to make sure that there isn't a bias component there. And I think ultimately it can feel really overwhelming, but just commit to doing one thing and start it. That's all it takes. And so I will end it with this James Baldwin quote, ignorance allied with power is the most ferocious enemy justice can have. And with that, I'm happy to take any questions.
Cardi, thank you. That was really terrific. We got references to Titanic and to ER. It's really interesting.
Showing my age, yes.
I wanted to ask a question. It looks like Ramon's also about to ask, but let me just ask you, in your study of the time period that oncology, I think I was one of the subjects in your study, and it's very interesting to see those differences in time spent. And what you didn't seem to control for was Black versus Hispanic patients and primary language. Because one of the things I noticed is that if I'm using an interpreter, in theory, that could take more time, but sometimes it takes less time. And I think that might be a confounder by pooling Black and Hispanic patients, or Spanish speaking, I should say. Many Hispanic patients speak perfect English, but some may speak a different language. Did you look at that as a factor?
Yeah, so that we only included English-speaking patients for this exact reason, because that adds a whole layer of complexity. It's important. I think it's important work for sure. It's just an added layer of complexity.
Okay, thank you. Ramon?
Yeah, mine is a very very data-driven question, which is, as you know, getting accurate race and ethnic data on our patients is always challenging. Is there a way to improve that? It just seems like it's always a barrier. We always have to exclude people that don't report. Is there a way we can sort of overcome this? Because it really does sort of tie one hand behind our back when we really don't get the full picture on that.
Yeah. So I would say based off of our cancer registry data for our cancer patients, we currently have about 20% of our population where we have an unknown race and ethnicity. And so while high, much better than it had been years before, through the Office of Diversity and Inclusion and work Pam Abner has done, they've set up peak training and modules so that all front desk staff learn how to ask questions about race and ethnicity, right? Because essentially this gets inputted into EPIC. It's how we get our data. And so they teach how to ask these questions in a culturally sensitive way, including questions around, gender identification and sexual orientation, or SOGI as it's called. And so all across the system, all of our front desk folks have received this training. And I think that has contributed to our improvements in numbers and data capture. But you're right, if we don't know who they are, it's hard to know what impact we're having on them.
And the other thing is we still have another category, correct? Other?
Other.
Yeah. What does that mean? I mean, I mean, is it really truly other, or is it just folks who are mixed race, or you know what I'm saying? It could, yeah. It really is. It's hard to define.
Yeah. I think it depends on what the source is. So other in our cancer registry data is, is a mix of the mixed races, but you can parse that out if you want them to. They have the ability to do that. And I think that's what ends up being in most studies when they report other, is just people who, picked multiple things or the non-common categories.
So just a couple of comments. This is being recorded and will be distributed by Dominique. So people who didn't have a chance to see this will get access to the talk. There's a question about Cardi about recommendations for discussing clinical trials with patients of color. What would be the way to do that? And maybe I'll add to that, how can people get training in implicit bias?
Yeah, so I would be happy to share this information. Currently, so there's the Cook-Ross method of training for implicit bias, and within the Department of Medicine, there are 4 trained people in this methodology, and so they can hold trainings for groups of people as we so want, and so we can work on doing that. There's also an anti-racism workshop that was moving full steam ahead, and then COVID happened, like it disrupted everything else in our lives. And so that's now getting back on track and trying to figure out how they're going to do that virtually so that that's an opportunity. And I would say in terms of addressing mistrust within clinical trials, I think the best way to start is understanding where the patient is. And it's simply just saying, tell me what you know about clinical trials. Tell me what worries you have, because that way you're not going in with your own preconceived ideas of what this person may or may not feel, and you can address the issues as they bring them up.
Jason, did Jason wanted to make a comment?
Yeah, so I wanted to comment about towards bias. And what I wanted to comment about was Mount Sinai recently had the experience. I know everybody was supposed to go to that. And if you follow the instructions, you find yourself sitting next to somebody who doesn't look like you, and they don't share. And it's kind of difficult initially to start a conversation because you don't have common things to talk about. You don't share common experience. So it's hard to get conversations started. But I shared at that meeting something that I was listening from a psychologist called Scott Barry Kaufman, and he said that these types of events are things that are actually very good to force yourself into these very uncomfortable situations, because what that does is that it challenges whatever bias that you have, implicit bias that you have, and it brings it from your subconscious to your conscious. and where you could have an opportunity to educate these biases and to be aware of how these implicit biases are actually influencing how you treat people. And the other thing I wanted to bring to this conversation here is at that experience, they also talked about empathy, and somebody made a point about empathy and how everybody has biases, and people tend to show empathy more to the people who look like them. And I found that at that meeting, there were like two conversations happening also, one on the main floor and one at the table. And the one on the main floor was a very polished conversation. And the one at the table was, I think, an equally conversation that should have been voiced because it sort of reflected the pulse of how people were feeling. Uh, uh, and the thing I was trying to decipher was what stopped this conversation from making it to the floor. You talked about giving people an equal voice. And one thing that I found that helped that conversation make it to the floor, if one or two people felt brave enough to voice their opinion, then the whole dynamic completely changed. So that was my contribution.
Thank you for your input, Jason.
Yeah. Okay.
Okay. Do you have any comments, Cardi, on that comment? Okay.
You're
So
exactly right.
yeah. So I think there's going to be more to come. We're at the bottom of the hour. I think the key here is that this is not just one presentation, although it was really a wonderful one. And I think both with Gary and Cardi kind of giving us maybe a little bit of an overview of where we have to start going. I think the key issue for many faculty, staff, people at Mount Sinai is, what can we do to get to this next step and really explore the tools and training and opportunities for us to really educate ourselves. I mean, because some of that data is pretty eye-opening, I have to say, and it includes us. It is us. So I think we're going to hear more. I think we should try to create really a series around this, particularly in healthcare. I don't know that we can change society, but we can certainly have an opportunity within the Cancer Center. Ramon is really very focused on the community outreach and engagement. This is going to impact both our relationship with our community, but also clinical trials and all of the things we're trying to do to impact, as an NCI designated cancer center, better care of our cancer patients. So I think there's going to be more to come from that, Ramon, correct? And I really want to thank everyone for joining us, and thank you, Cardi and Gary, for really talking about this very important subject, and for really a wonderful talk, Cardi. Thank you. All right.
Thank you. Great talk.